On behalf of our faculty and staff and students, I'm just delighted to welcome you here to Thiel and to the third annual Haer Family Symposium. The symposium is dedicated this year to brain awareness, human brain awareness primarily, according to my understanding. It has been observed about the human brain that it is indeed a marvelous and mysterious organ. It starts to work as soon as you are born and does not stop until you get up to deliver a speech. Still, though, we all keep trying. Last evening, we heard from a panel of those involved here at Thiel in the disciplines of neuroscience and psychology, and in working with our students to prevent, treat, and provide accommodations for concussion. Tonight in Bly Hall, beginning at 7:30, we will view and discuss the film Concussion. You are all invited. I'm told there will be popcorn. The Haer Family Symposium is made possible through the generosity, wisdom, and foresight of Thiel alumni Fred and Jill Haer, and we thank them most sincerely. Here to introduce our keynote speaker for Brain Awareness Week is Chair of Thiel's Department of Neuroscience and leading light in advocating for brain awareness and brain health, Dr. Greg Butcher. Greg?
Thank you, Dean Franken. Dr. Collins, our speaker today, is the director of UMP's Sports Medicine Concussion Program, which is the first and largest research and clinical program focused on the diagnosis, evaluation, and management of sports-related mild traumatic brain injury in athletes. He's a graduate of the University of Southern Maine with bachelor's degrees in psychology and biology. And during that time, he was also a student athlete and competed in the NCAA Baseball College World Series in 1998. He then went on to earn master's degrees in psychology and a Ph.D. in clinical psychology at Michigan State University. In addition to training physicians and athletic trainers, he is the co-lead author of the CDC's Concussion Toolkit for Physicians, which has been disseminated nationwide as an education standard regarding concussion management. Today, he will discuss advances in clinical management and treatment of sports-related concussions. And I'd like to welcome Dr. Collins to the stage.
Thank you very much. It's nice to be here. Beautiful day. I can't believe you guys are all in here watching me speak when you could be outside. And by the way, it wasn't 1998, it was 1989, so I'm going to date myself a little bit. That was a while ago. But anyhow, it's a pleasure to be here, and nice showing. I see a lot of students, and this topic this afternoon is of interest to a lot of different people, and quite frankly, I think there's a lot of information out there about this injury where it's left people a little confused. I arrived at UPMC in 2000, and I started at the Center for Sports Medicine in September of 2000, and I can tell you that for the first 5 years, I sat in a cubicle, and I kept thinking that Dr. Fu, who's my boss, is going to tap me on the shoulder and said, "It's time to leave, Mickey. You're not busy enough," okay? And it was interesting at that point in time, not many people really cared about concussion. And, I got interested in this topic in the late 1990s when, Steve Young had an injury and Troy Aikman had an injury. I'm dating myself again. And, I said to myself, that's an interesting area. And come to think of it, not many people were doing it at the time. But we started doing work in the area around that time. And boy, it's been a wild ride since that point. Fast forward 16 years, and we have 20,000 patients to our clinic every year. 20,000 patients to our clinic on an annual basis. And I got to tell you that we've made more advances with this injury than I ever thought possible. We actually can treat this injury the great majority of the time. And so what you're reading in the media, it juxtaposes not very well with what I see on a day-to-day basis, which is kids getting better and getting back to the sports they love. And I think the pendulum has swung from here to here, and the truth is somewhere in between. It's worse than we thought, but I don't think it's as bad as it's being made out to be. And I'm here today to share with you some of the advances we've made with this injury and how we look at it, how we evaluate it, how we assess it, some of the research showing what recovery looks like, and just kind of getting in and trying to educate you about this topic that is obviously very important. So without further ado, this afternoon what I really want to do is accomplish the following. I'm going to briefly describe some of the current topics of concern with this injury. I'm going to talk about what actually happens in the brain when we have a concussion, and so you understand exactly what we're dealing with from a pathophysiologic standpoint. I'm going to present to you 7 common misperceptions of this injury and state the scientific facts, and some of that information may surprise you. I'm going to talk about the advances we've made in terms of treatment of concussion and how we actually assess the injury. What do we look at, and how do we measure it, and how do we define recovery, which is tricky, but it's pretty coherent when you really break it down. I'm also going to talk about how we're starting to identify that there's different types of concussions. There's 30 different types of knee injuries. Why do we think there's one type of concussion? We've actually been able to identify 6 different types of injury, and I'm going to talk about that a lot as well. And lastly, if I'm not too much of a windbag, which I've been known to be, I'm going to try to present a case at the end of this, but I'm going to try to keep this within an hour here, so let's get going. All right, so the topics of concern with this injury are still many. Had a good conversation just before arriving here that, there's, in terms of this injury, we really have made a lot of progress, but there's still so many scientific questions that haven't been answered. And that's what makes it fun. My feet hit the floor in the morning, and I can't wait to get to work because I learn something new every single day. And we need so many advances with this injury. There's so much more we have to do, which is exciting. But, reality is currently there's no imaging technique. I could give you the fanciest MRI, CT scan, PET scan, MEG, fMRI, all these different fancy imaging modalities that we've used in our clinic, and I can't show you concussion. The things that happen with this injury in the brain are at the neuronal or cellular level, and we don't have a way of measuring that. So there's no blood test, there's no biomarker to look at this injury, which makes it challenging. Also, contrary to popular thought, there is not any prospective long-term research looking at what this injury may do to you in the long run. There's no 40-year study, 50-year study following kids from Pop Warner until they're 50 years old or 60 years old looking at what the possibility of long-term problems are. And so what you're hearing in the media about concussion, although very concerning, there isn't any research that says concussion in and of itself is what's causing that pathology that's described in the New York Times, et cetera. In fact, as scientists, I can tell you, we had a meeting in Pittsburgh this year. The best scientists in the world on this injury came together, and we really don't have answers as to what the long-term effects of this injury are. So much more work needs to be done. We also, to date, have not had a way of actually targeting treatment for concussion. I'm going to talk about that a lot. Also, if you send your kid to 20 different pediatricians, you probably get 20 different answers as to how to manage the injury, when to go back to play. There's so much variability in clinical management of this injury. We have a lot of work to do as leading clinicians trying to disseminate the right information out there about how to treat and manage and get these kids back to play safely. Another issue is that rest doesn't cure all concussions. How many of you in this room think, dark rooms are the way to go with concussion? They're not. In fact, we've actually come up with more active strategies at treating this, and I'll talk about that a lot. And lastly, there's just so much talk about concussion out there that, the awareness is great. I love to see the awareness of this injury, but awareness with no solution is called hysteria. Awareness with no solution is called fear. Awareness with a solution, with treatment solutions, is called good management. And that's where we need to go as a field, is to really start changing the conversation here that there have been advances made. Probably never been safer to have a concussion than it is right now because we've made so many advances. And that's how I feel about the injury. So let's talk about what happens in the brain when we have a concussion. So here's a video of a kid. Can you play the video, please? You're going to see him get hit against the boards here. Oh, go back one. I can play it. There you go. So if you watch this kid here, it's going to be over here somewhere. All right, if you can, next slide. That's what I do on a daily basis, is treat that. And I can tell you that what you see on the eye is scary, right? I mean, the word concussus literally translates from Latin to English to mean to shake violently. Think about your brain as an egg yolk inside an eggshell, the eggshell being the cranium, the egg yolk being the cerebral spinal fluid, and the eggshell and the actual yolk of the egg being the brain. We will never be able to prevent that egg yolk from moving inside the shell. And it moves in rotational ways, it moves in translational ways, and the movement of the brain inside the skull is what causes the injury. Now, there is no helmet in the world that's going to stop the brain from moving inside the skull. And helmets are not the answer. We've actually done a lot of research on that. And until we find a helmet that goes around the brain itself, there's not a whole lot we can do about the movement of the brain inside the skull. It's going to happen, okay? Now, when the movement of the brain occurs inside the skull, what causes concussion is this. How many neuroscience majors do we have in here? All right. So maybe I should ask you in the red hat. No, I won't. But anyhow, we have more neurons in our brain than there are stars in the sky, okay? And each neuron's connected by an axon, and one cell talking to another cell through these chemical exchanges between the cells and the neurons is what allows us to behave as human beings, okay? What causes concussion is this, is when the brain moves in the skull, there's this little chemical called potassium that's supposed to be inside the cell. And when the brain moves in the skull, that membrane will stretch, and potassium, which is supposed to be inside here, gets leaked out. When potassium gets leaked out of the cell, there's an increased demand for glucose or energy. And so the cell is actually saying, whoops, something's wrong, I need more energy. That's number one. Number two is calcium, which is supposed to reside outside the cell, will leak across that same stretched membrane and go into the cell. And guess what happens when calcium goes into the cell? We get vasoconstriction. Anyone know what that means? That means your blood vessels constrict. And at the very time the brain's demanding more energy, we actually get reduced cerebral blood flow, which is what supplies energy. And so all concussion is this energy problem that occurs inside the neuron. Okay, that's it. That's what concussion is. Release of potassium, increased demand for energy, influx of calcium, vasoconstriction, reduced cerebral blood flow, less supply of energy, voila, energy problem. And that energy problem is what causes the behavioral changes that we see with concussion. What we know is that during this period of energy crisis, there's one big thing that you don't want to do. What is that big thing? Come on, Joe student over here. What do you say? What's the big thing you don't want to do? Get hit in the head again. It's not that hard. We know that when this brain is starved for energy, a secondary blow is going to cause far less force, is going to cause far more problems, and cause, and you see this all the time in sports. Guys that are injured, they go back to play, they get hit again. Bad stuff happens when that occurs. It doesn't kill you necessarily, hopefully not. It can, by the way. There's something called second impact syndrome that can cause catastrophic outcomes. Very rare. But the more likely scenario is that you see patients take longer to recover and they have a hard time recovering from the injury. So the best way to prevent a problem with concussion is to manage it effectively when you have one. And you got to make sure this energy problem gets back to normal. Well, how do you determine that? That's what I do on a day-to-day basis, is help determine that issue. And we've made advances in understanding how to do that. But we have to do it through a clinical evaluation because we don't have a biomarker to determine this. Everyone understand that? And so you got to roll up your sleeves, ask the right questions, use the right tools, look at the right data, know the patient you're seeing, and put that all together to determine when is it safe to put these kids back to play. I want to go through and present to you 7 mythologies of concussion, okay? What I call neuromythologies, or misconceptions of the injury. And some of this information may surprise you, but I'm going to present the myth and I'm going to show you the scientific facts. Number 1, a concussion only occurs when an athlete loses consciousness. 90% of concussions do not involve a loss of consciousness. And, Yeah, 90% of concussions do not involve a loss of consciousness. In fact, how many of you realize that being dizzy on the field is 7 times more predictive than any other symptom in predicting a worse outcome? If you have dizziness after a head injury, you're 7 times more likely to have a more complicated recovery. And that's 7 times more predictive than losing consciousness. In fact, if you lose consciousness, you're more likely to recover within a week than other symptoms. Losing consciousness might actually be protective of the brain. You may not know that. Mythology number 2. Everyone is at the same risk for concussion. Not so. Various factors that we've shown through our research show that kids that have these factors have a worse outcome. Patients with a history of migraine. Patients with a history of car sickness. Imagine that. How many of you have a history of car sickness in this room? Okay? You are more at risk for a worse outcome from concussion than me. How many of you have a history of migraine? You're way more at risk for bad outcomes. Okay? We've also learned that girls are more at risk than boys in terms of recovering from concussion. Younger kids are more at risk than adults and professional athletes in terms of taking longer to recover from concussion. We've started to identify, if we lined up 100 people and hit them in the head, certain people are going to go down with far less force than other people. And those people are the ones with a history of lazy eye or car sickness or migraine. Those are the patients that are most at risk. And now that you understand concussion's this energy problem, it kind of makes sense. If you have a history of a lazy eye, strabismus, amblyopia, okay, and your eyes are weak, how many of you have a history of that in this room? Well, it's pretty fairly common, okay? And concussion's an energy problem. If you already have that issue, the energy crisis will decompensate that system way faster than someone that doesn't have a history of a lazy eye. And that's why we see these certain risk factors occur. The good news is that people will decompensate quicker that have that history, but they'll actually recompensate faster and recover faster if they get the right treatment right away. Number 3, it's safe for a player to return to the same game or practice after suffering concussion-related symptoms. Absolutely not. We do not want to put kids back to play that have any signs or symptoms of injury. The tricky part is that this is a very invisible injury, right? It's not something that's outward. You're not like you're wearing a cast on your head. And we've actually shown through our research that the signs of injury predict less than the symptoms of injury, meaning signs are what you observe in a patient and symptoms are what the patient's reporting. Symptoms are way more predictive of poor outcome than are the signs. For example, if you vomit on the field, you're less likely to have a poor outcome than if you have dizziness. Okay, and dizziness is self-report. So the symptoms that predict the longest outcomes are the ones that the patient has to tell you because you can't observe it. And so therefore it leaves athletic trainers and sideline physicians it's tricky. This is not easy to do in terms of identifying kids that are concussed. But with awareness, I think that issue's been helped. I work with the Steelers, and I know that this past 3 or 4 years, we've had so many guys kind of reporting symptoms of other guys. That's helping a lot, and you've seen that in some of the cases recently. And so it's occurring more where athletes are better aware of the subtleties of the symptoms, and that's where awareness has been a very good thing, okay? Myth number 4, all concussions, treatments, and recoveries are alike. Not the case. No 2 concussions are identical. In fact, I often feel that concussions are like snowflakes. Everyone's a little different. They recover differently. There's different stuff going on. We, through our program at UPMC, have now been able to identify that there's 6 different types of concussions. All right? Here's what they are. When that energy crisis happens in the brain, we've now been able to identify that there's 6 different problems that can occur. Vestibular dysfunction. How many people know what vestibular dysfunction is? Vestibular dysfunction, it's a part of the brain that allows us to interpret motion. It allows us to stabilize our vision when we move our head, okay? It allows us to cancel out busy environments. It allows us to balance. It allows us to integrate sensory information. Like if I was in a room right now like this with a little bit of movement going on in a busy place and I had a vestibular problem, and I had a concussion, that signal comes through aberrantly because it's an energy crisis, and the sensation I would feel right now if I had a concussion is I would feel one step behind, detached. I'd feel this slow, wavy dizziness, almost like you're on a boat. I'd also feel probably a little bit of a headache. I'd feel tired. And what's really interesting is when patients have vestibular dysfunction, the same parts of the brain that control emotional functioning. So patients that have vestibular dysfunction feel anxious. They get this autonomic arousal where their heart rate increases and they get really anxious in environments like this. And that can cause a lot of problems because how do you think you treat a vestibular problem? Anybody? I'll give you a second chance over here. I'll keep calling on him until he answers something right here. How do you treat a vestibular problem? By doing the things that bother you. It's not by rest. You have to retrain the system. And so if you have a kid that has this type of concussion that goes to his pediatrician, the pediatrician says, sit in a dark room, turn off the TV, don't use your phone, don't go to school, you don't get better. But there's other types of concussions that if you push a kid too hard, you can end up with problems. What I'm trying to convey to you is this is a complicated injury. You need to see someone that knows how to manage it. It's critical. Ocular dysfunction. 65% of the brain is devoted to eye movements. And when that system decompensates, kids have a hard time with math, hard time with science. They get these frontal headaches, okay? They feel really tired at the end of the day. And their math grades can drop, calculus can drop, complex visual processing can become a real problem. Now, this type of patient doesn't get dizzy. They can work out until they're blue in the face and not feel any problems. But when they go down and take a math test, they struggle. See how different those two injuries are? We have treatments for that. Guess how we treat that? By retraining the visual system. We have incredible rehab for that. Cognitive fatigue. I could go through these slowly and carefully, but it's really interesting when you start to understand what's really happening. These are the patients that actually push through all the deficits. This is the hardest patient that I have to treat, and it's really complicated because patients that don't get managed right and push too hard through the injury and keep playing through it are the ones that I have the hardest time treating because they kind of re-habituate in a way that's not right, and they build on a bad foundation, and we see chronic levels of fatigue and mood changes and problems. If there are patients with long-term problems from concussion, it's these patients, okay? We treat it through medication in that type of patient, but it's harder for me to treat that patient. It's a little bit more dangerous, and that's why you got to be so careful in managing it correctly when you have it. Migraine, huge problem with concussion. It's the number one predictor of patients to have a bad outcome. And patients with migraine, if it's truly post-traumatic migraine and it comes on from the concussion, and remember that vasoconstriction we get where the blood vessels constrict, that can trigger migraine in patients that are susceptible to it. And when the migraine genie comes out of the bottle, the migraine genie is hard to get back in the bottle. And if you push those patients too hard, they don't do well either. I'm going to work this patient out really hard. That's the patient where I might not put them back to school for a few days. I'm going to recommend certain behavioral management things. We may need to use medications. There's a lot of different things that can happen with that. Cervical, neck stuff, and we see a lot of patients with anxiety that is likely biologically triggered by vestibular dysfunction and other systems in the brain. So we see patients with emotional changes with this injury all the time, and you got to be really careful with that. So what I'm trying to convey to you is that it's a complicated injury, and to make it even more complicated, do you realize there's probably 30 different types of ocular problems that can occur after concussion? There's multiple different types of vestibular problems, there's different forms of anxiety and depression, and each of those deserves specific treatments. Okay? It's complicated, but it's also kind of fun. Because we get patients better when you know how to break it down and treat it the right way. Myth number 5, you must be placed in a dark room to recover. I've kind of addressed this already. There's certain subtypes of concussion that you're never going to get better by doing that. And there's certain subtypes, I'd never put someone in a dark room, but there's certain subtypes that you don't want to push too hard either. Manage it individually rather than in a cookbook way, and you're going to be okay. But a lot of clinicians out there that don't understand the subtleties of this will recommend dark rooms for kids. And guess what happens when you get put in a dark room, not literally, but when you get shut down, you can't go on Facebook, you can't text your friends, you can't watch TV, you can't go to school, you can't play sports that you love, you can't exercise. What do you think happens? Nothing good, I can tell you that. It actually causes migraine in patients because people get migraine when they don't exercise, when they nap all day long, okay? When they're anxious. That triggers migraine in people. And then when that genie comes out of the bottle, it's really hard to treat. Having one concussion places you at increased risk for future concussions. Not so. We've actually found that if you manage the injury properly, we shouldn't see increased recidivism. If it's treated right, you shouldn't be at more risk. And you know, this information out there that if you have one concussion, you're 4 times more at risk for a second one, no, you're not. Get it treated right the first time, and we can literally hit the reset button on you the great majority of the time. Just get it treated. What we know is that patients that do have repetitive concussion, it's usually because they have something going on that hasn't been treated. They got an ocular issue, they got a vestibular problem, they got anxiety, they got migraine, and it hasn't been treated right, and they keep getting concussed. If you have a patient that's had 3 or more concussions in a year, would you please get them down to Pittsburgh so we can see them? Because we can probably treat it. Don't retire them, get them treated, and we can hopefully get them back to play safely. And lastly, concussion myth number 7, all concussions and subconcussive injuries, quote unquote, definitely cause long-term brain damage and chronic traumatic encephalopathy. No, it doesn't. You're going to watch a movie tonight, and it's going to scare the living bejesus out of you, okay? I can tell you that I watched that movie with people that were in the movie, and we counted at least 30 to 40 mistruths in that movie, at least, probably more. There's so many things in that movie that's not accurate, and it's sensationalized. Sorry. Am I on tape? Probably. It's true. Yes, I am. Yeah. Look, CTE scares me as a clinician. I see athletes from all over the place that I see cases that I'm worried about in terms of that. I see really bad stuff in my clinic every day, okay? I saw this guy from Germany yesterday that's like had how many concussions, and he's really struggling, and you know, he's got that cognitive fatigue stuff going on and other things going on, and we're going to be able to get him better, but he's a case that worries me. And you know, I'm not saying that this construct doesn't exist, because something's going on. We just don't know if concussion is what's causing it. It could be so many other factors that's causing it. We don't know the exposure rates. We don't know the base rates. We don't know if this is another form of like Alzheimer's disease or something that we haven't been able to identify. We don't know if what the frequency of this is in a normal population. You know, that's not talked about in the movie. All those things. What's shown in the movie is it scares you to death, because when you watch the movie, it's going to be like everyone's going to get CTE. Well, they don't. All right, there's a lot of people out there doing great, having played a full, you know, NFL career. So just be smart, be logical, be critical when you look at this stuff, and understand that it's, you know, it goes beyond what you're going to see in that movie. It's more complicated. Potential long-term effects may occur, okay? But we feel very strongly that this is a treatable condition if it's caught early and done the right way, and that you can really mitigate problems by managing it effectively when you have it, managing it effectively when you have it occur. All right, so what I want to get into now is I'm actually going to briefly go through kind of how we approach this injury from a clinical standpoint, and just share with you sort of our clinical. How many clinicians do we have in the room? Well, you might find this next part really boring, but that's okay. So but I think it will give you a good insights as to how we look at the injury. So this is where I work, okay? That's my office right there. That's Dr. Fu's office, who's got a much nicer office than me. But I got to tell you, I'm closer to the river than he is, just saying, you know. I mean, but anyhow, but we work in, and that's the Steelers building there. It's a really nice place if you haven't been down there before. At our program at UPMC, we have the largest program in the country. We see 20,000 cases a year. They come from all over the world. 30 to 40% of my patients are out of state, but I see a lot of local cases as well. If you call, you'll get in. But we get referrals from emergency rooms, primary care practices, athletic trainers, a lot of out-of-town referrals. I'm a clinical neuropsychologist working in orthopedic surgery. There's got to be a joke in there somewhere. But as a clinical neuropsychologist, I'm trained on brain behavior relationships, and it's kind of an interesting field that I love. But it allows, we have 8 full-time neuropsychologists as part of our staff. We're the point guards of the program. So the patient comes to us first, we see the case, but in the same building as us, we have all these folks as well. We have primary care sports medicine, we got physiatry or PM&R, we have orthopedics, we have vestibular therapy. How many of you have ever heard of vestibular therapy? It's a wonderful thing that we have 35 vestibular therapists as part of our program, 35 of them. They do our physical therapy in treating the vestibular dysfunction that we see from the injury. We have behavioral optometry. What in the heck is behavioral optometry? Well, it's some dude in a bow tie that fixes your eyes when you get a head injury is what it is. But a guy named Nate Steinhoffel is involved in our program. Wonderful human being. I think you've probably seen him, some of you. So anyways, we have a whole assortment of treatment specialists, and depending upon what the patient's problems are, they can get referrals to those clinicians in the same day and get seen and treated, okay? When we assess this injury, meaning how do we evaluate and measure the injury, we actually look at the injury across these 5 domains. Cognitive functioning. How many of you have heard something called the impact test? Okay. The impact test is a test that we developed that is used in through a lot of different sports, and it's a 20-minute battery of tests on a computer that measures things like reaction time and visual processing and memory, and it's this really it's a really difficult 20-minute test that we can measure the injury by putting the brain to work, and that really helps us understand what's going on. But the impact test is not the only thing we look at. We also look at vestibular dysfunction. Now you know what that is. We have tools to measure that. There's ocular motor stuff that we do, or eye stuff. We obviously ask about symptoms. And if you come see me, you're probably going to work out, because if I can work you out, I can understand if there's a vestibular component. We work in sports medicine. I'm going to get you active, and I'm going to see where the system's breaking down. And I actually can treat it once I understand where it's breaking down. Like we have patients that have a hard time with their vertical head movements. I can treat that if I understand that's where it's coming from, okay? So there's all these different movements that can cause dysfunction, and we can actually rehab that by retraining those systems. And it's also sport specific. If you're a cross-country runner, it's entirely different than if you're a hockey player. Hockey's the most demanding sport from a concussion standpoint, because, how many sports are you traveling at 25 miles an hour looking over your left shoulder on a white sheet of ice with the boards going by you like this, having to pick up this little tiny thing in your field of vision, and then have to react appropriately when it comes your way. That's a complicated vestibular function. And there's no other sport like it in terms of the speed and all that kind of stuff. And that system breaks down. It's not good for the hockey guy, It just takes more time to treat it a little bit. But that's how we measure the injury. Once we measure the injury and we get this information, we can establish diagnosis. We can establish prognosis. We've done research which shows if you have these problems going on, it's going to take X amount of time to recover. I don't want this to sound trite, but I look at concussion as like an orthopedic injury. That's the way I want it to be. This is the type of concussion you have. This is how long it's going to take to recover, and this is what we're going to do to treat it. Imagine if we had that information. Do you think the hysteria of this might die down a little bit? I think it would, but that's how I feel about it. It's very manageable once you understand how to manage it. We can also determine academic issues. Like if you have an ocular problem, you got to be careful with that as it relates to school. If you have a vestibular issue, hallways are going to bother you, cafeterias, and you can figure all that stuff out. But the academic accommodations can only be done once you figure out what type of concussion you have. And, everyone's different as to what type of accommodations they need. I've never done the same accommodations for the same patients. For different patients. It's going to be individually determined. And by the way, I'm not going to give accommodations unless they're absolutely needed. Because, again, getting better from concussion is about retraining. It's not by avoiding. Make sense? We can also determine specific rehab stuff and return to play expectation. And most importantly, as parents, when a parent comes into our clinic and they sit down and they actually listen to what's going on, boy, it helps them out, because it's this mysterious thing until they really understand what's happening. And once you explain it to them, it usually goes pretty well. Now, again, this model is gaining a real significant momentum from a scientific standpoint. I'm a clinician. I see 25 patients a day, 5 days a week, okay? But I'm also a researcher. We do a lot of research on this, and there's a growing empirical support for these different types of concussions. And you're going to see that come out in the literature and, over time. So let's briefly go through a quick evaluation. I do mean briefly. These are the 3 essential components of an evaluation: talking to the patient, finding out what symptoms they have, doing vestibular ocular motor stuff, and doing neurocognitive testing. We have actually created a new tool called the VOMS. Anyone ever heard of that? The VOMS is a horrible name, sorry. It stands for Vestibular Ocular Motor Screening. And we've actually created a tool, it's a 5-minute exam, that helps us screen for people with vestibular ocular motor deficits, okay? And we created this tool so clinicians could have a screening way of evaluating the vestibular ocular motor system, and this is starting to become almost as widely used as Impact is now. It's something that's going to gain a lot of momentum here. But I'm not going to spend a lot of time, but we look at things like smooth pursuits, which is your eye movements. We look at, that's following a target. Saccadic eye movements are here. We look at the eyes movements vertically in horizontal directions, and we ask what symptoms they're having when they're doing this. We look at what's called near point of convergence. This clicker's not working. Here it is, where everyone should be able to converge. When you look at a target, if I showed a dot here and brought it to my nose, I should see one dot that's 5 centimeters or less from the tip of my nose to where that dot becomes 2 dots, or what we call diplopia, okay? If you are unable to converge your vision, it's a very common sign of concussion, and we see a lot of patients who can't converge their eyes appropriately, and we see a lot of patients that have what we call an exophoria, where their eyes will drift off. Oh my goodness, if you see that, it's got to be treated, because it's going to be a big problem for kids, and they're going to have struggle in school, okay? And so we can look at that with this evaluation. We also look at something called the vestibular ocular reflex, big word. All that means, everyone put your thumb out. Stick your thumb out and move your head like this and look at your thumb, okay? Keep doing it. Keep doing it. Come on. Come on. Let's go. Let's go. That is called the vestibular ocular reflex, which allows us to stabilize our vision when we move our head. And when there's an injury, what you just did would make you feel really badly, okay? And we do it both in horizontal directions and vertical direction, all right? How many of you got dizzy doing that? This big guy right here is going after it. I like it. How many of you get dizzy doing that? You shouldn't get dizzy doing that. If you have a history of car sickness, you might be able to get a little dizzy doing that. And those are the patients that are going to have a harder time recovering from concussion, okay? So we give this test to all the Steelers before the season starts, all the Penguins, and we can understand if they have any of this stuff going on. And then when they have an injury, we understand what their baseline is, okay? So this type of stuff is very important to look at. There's also something called visual motion sensitivity, which you actually cancel out the vestibular ocular reflex, where you, if you just stick out your thumb, don't hit your neighbor, okay? But now look at your thumb and just go around the room like this. And that's a whole different function of the vestibular system. And that breaks down very rapidly in patients with concussion, and that's the one that causes a lot of anxiety in patients, actually, believe it or not. How many of you know that a history of car sickness predicts anxiety, and a history of car sickness also predicts migraine, okay? And you see how that stuff all predicts bad outcomes? See how it all fits together? How many of you realize that girls are 4 to 6 times more likely to get migraine than boys? That's why girls have a worse outcome from concussion. How many of you have a history of migraine in this room? Raise your hands. Hi. One female, got a male right there. Joe student over here. What is your name anyways? Nick. All right. I'm Mick, by the way, so I'll remember that one. Yep, so girl. So, it's mostly girls that have migraine, except Nick over here. He's got them too. All right, so we've also done a lot of research looking at this thing called the VOMS. I'm not going to bore you with the details. Long story short, it works. Let's move on. Okay. We also have much fancier ways of looking at the system than a 5-minute screening examination. Okay, we have a test called the gaze stability test. You see this? This used to be the running back for the Washington Redskins right here, who had a bad concussion. And he is looking at a screen that has an E that points left, right, up, down. And then we have this accelerometer on his head, and he moves his head rapidly, and we can actually measure at what velocity he loses that target stimulus, because he has to say which way the E's pointed, And we have normative data on this in so many different patients with different sports, and this is an injury. This is something that breaks down very rapidly in patients with concussion, and we can actually measure it by looking at that gaze stability stuff. All right. We also have some fancy balance things we can do. We look at the eyes in very complex ways. We have these things called infrared goggles. It looks like Hannibal Lecter, you know. But what that allows us to do is look at their eyes in darkness. And when you look at eyes in darkness, you can actually see if there's nystagmus or eye movement changes or anything. And it's very sensitive. It's another way of looking at the ocular system that you can't see with the naked eye, so to speak, okay? And we do all that stuff with these patients to better identify. The question I ask as a clinician is, where is the aberrant signal coming from? What's happening? You know, what's going on? And then we attack it through treatment. All right, computerized neurocognitive testing, not to bore you. The impact test was developed by Mark Lovell, who's really the genius behind it. Joe Maroon, I rode coattails way back in the late 90s. And, you know, this test has been used very widely now. I think it's been used, it's being used all over the world. It's in 20 different languages. It's something that's used in the NFL, NHL, Major League Baseball, blah, blah, blah. It's used by a lot of high schools. How many of you who played sports in high school took this test as a baseline? Raise your hands. That's pretty cool. Kind of neat. We developed this out of our garage, by the way, back in the mid-1990s, and it's true. But anyhow, that test has been used very widely. But please understand, this is a tool that needs to be augmented by the right evaluation. This isn't a biomarker, okay? Like, I don't manage concussion looking at an impact report. I manage concussion looking at this as well as all the other things we've developed and looked at with the injury. And it needs to be folded into the right evaluation to be used the right way. So critical that people understand that. This is not a black and white kind of thing. And by the way, there's so much information in this test. The raw data is way more helpful than the summary scores is for me. Like, when I look at the raw data, you got to make sure the right people are looking at this information to make the right decisions. But it's been used a lot in sports, and it's been researched extensively. I think there's 225 peer-reviewed papers on it. It's widely implemented. All right, so what are we learning from outcomes, okay? When we use the tools that we have, what do we learn in terms of recovery? Well, what we learn is that, here's a study we looked at over 2,000 high school kids in Western Pennsylvania, and we followed their recovery over time, and we defined recovery as this is back when we just really looked at neurocognitive testing and symptoms, okay? That was before the vestibular ocular stuff, but this is a study we looked at a lot of kids, and we followed them over the course of 3 years, and we monitored them, and we determined how quickly it took to recover from concussion in a statistical research way. And what we found in that study, and the times have extended a little bit since we've added the vestibular stuff, but we found out that about 40% of kids get better in a week, 60% by week 2, and 80% by week 3, meaning 1 out of 5 kids took more than 3 weeks to clinically recover from this injury, okay? And so you can't cookbook this injury. You see this kid right here? He got better in a day. This one here never got better by the end of the study period. So there's tremendous variability in outcomes from concussion. And what our research has been focused on since this study came out is identifying who these kids are. These kids that take 3 or more weeks to recover, and boy, have we learned a lot. In fact, these are all the published papers we've had on that topic, where we found out that younger kids take longer to recover than adults, and we found out that migraine predicts outcome and learning disability and being female and motion sickness and ocular dysfunction and dizziness. So, you know, we've really been able to better identify who these patients are now that we've looked at this recovery thing. And that's the cool thing about research is being able to do these types of studies. And here's another study that we have coming out that's not published yet that I think is very interesting. And this is a study where no one's actually examined the research question as to if you have a concussion and you have symptoms of that injury and you play through those symptoms, do you differ in terms of outcome than patients that have symptoms of concussion that report the injury and are taken out of play immediately? No one's ever looked at that from a research perspective, so we did. And this study's coming out soon. But we simply put, I'm not going to bore you with the scientific details too much, but what we looked at is we looked at neurocognitive testing or impact at baseline. We also looked at the VOMs. And then we looked at 138 patients with concussion, and half of them, this is a complicated slide, but 44 of them had symptoms of injury and immediately reported those symptoms, were taken out of play, and they didn't go back to play until we cleared them, versus 51 of whom patients who had symptoms of concussion that didn't report it, and they played through it, okay? And on average, they played 24 minutes beyond the point of their injury. Just 24 minutes on average, all right? And then we looked at the differences in recovery rates between those two groups. Kind of a cool study, isn't it? I think it's cool. I'm a little nerdy with this stuff, but I think it's kind of neat. And what we found, and I'm not going to get too much into this, but this is a group that wasn't removed. Here's where they are at 1 to 7 days post-injury, and here they are at 30 days post-injury, okay? And this is the group that got removed. And I know that it's hard to explain statistics, but that's a huge statistical finding between groups. And we found it across every single measure, across every single possible measurement point, neurocognitively, on the VOMs, et cetera, et cetera. There are huge differences in kids that come out of play in terms of getting back to play faster. We can get them on the field. So it's really not very smart to try to play through this injury. It's really kind of stupid, actually. And if you can come out of play when you have the symptoms, even though it's really subtle and it's hard to understand what the subtle symptoms are, you're going to see big differences in outcomes. In fact, the group that was removed recovered on average in 19 days, and the patients that weren't removed from play took on average 35 days to recover from their injury. And so you just missed an additional 2 games in football if you kept playing through it. That's the kind of data that I could help a lot of people understand that, yes, question.
Yeah, what about a year later? Did you do any longer-term studies on recuperative? Did they ever come up to even?
Yeah, once they come up to even, and we get them, they do well. So we didn't do that here because this was just done, but we could do prospective studies moving forward, sure. But we're not finding deficits and problems in patients once we treat it right, okay? And so when you're recovered from concussion, you're pretty recovered, all right? And that needs to be researched more, for sure, but we're not seeing long-term deficits in patients that are managed the right way. Yes? We don't know, and that's really a hard question to answer, and it hasn't been done. And that's what I'm referring to when I talk about the research hasn't been done, looking at what the potential long-term effects of injury are, because there are many patients that will play through this stuff that don't get treated, and I ask that question every single day. It's a great question because it scares me. With the things I see in clinic and how sick kids are with this injury, to think of them not getting treated, there is a big worry for me with that. Absolutely. So, in summary, what are we learning? A lot. There's so much we're learning about with this injury. Outcomes from the injury are highly individualized and variable. You can't treat this injury with a cookbook, okay? It's got to be managed individually. And the brain is the most complicated organ in the universe. It kind of makes sense, right? Athletes with concussions should be seen by a specialist. We really feel this is becoming a specialist-driven injury. Like, you got to get kids to be seen by people that know how to use the tools and use the right tools. And it's very important that kids be seen by specialty clinicians when possible. And that's not, I drove in here this morning and I realized, where am I, by the way? And by the way, I'm from rural Maine, all right? The town next to me was a number, okay? So this was a nice feel coming in here. But basically, we're learning that active approaches to treatment are effective. Concussion awareness with no solution, I talked about that. That's my little tagline, I like it. Important to recognize the injury and facilitate appropriate referral. And I think it's really time to change the conversation. This is an injury that's manageable, it's treatable most of the time. We have a lot to learn, but there's a lot of progress that's been made. And if I did my job this morning, hopefully you now understand a little bit more than you did when you walked in here. There's my kind of closing slide. It's kind of the money slide. You bring these things to the table, you get hit in the head, you get these problems, you get treated, and everything's cool. Thank you very much. Appreciate it.